Imagine a quiet Tuesday. You bring your laughing 86-year-old father in for a quick test. An hour later, a grim surgeon emerges. There was a complication. His colon ruptured. He never came home. That nightmare is exactly why my dad had a routine colonoscopy at 86. The doctor punctured his colon, and he never came home. Today, we are uncovering the hidden dangers of elderly screenings. I will reveal 7 crucial facts, hidden risks, and life-saving alternatives every family must know before consenting to this procedure. Let us begin by tearing down the most widespread, deeply ingrained, and physically dangerous myth that circulates in hospital waiting rooms and standard clinical practices globally. There is a pervasive assumption that because an intervention is common, it is inherently benign. Doctors frequently say, "It is just a routine procedure. Everyone gets it done. You will be fine." Listen to me very closely. When we are talking about patients over the age of 75, and especially those entering their mid-80s, this normalized language is a profound misrepresentation of physiological reality that can send a beloved family member straight to a surgical intensive care unit. To understand this, we must examine the microscopic architecture of the human digestive tract and how it degrades over decades. Imagine your large intestine as a high-performance inner tube of a bicycle tire. When you are 40 years old, that biological rubber is incredibly thick, highly elastic, fiercely resilient, and structurally tough. You can stretch it, manipulate it, and pump it full of air, and it bounces right back to its original geometric shape without a single micro-tear. Now, you must imagine that exact same inner tube after 86 years of continuous, unrelenting daily use. Physiologically, the tissues change at a fundamental cellular level. The vital collagen proteins that provide structural integrity deplete drastically. The elastin fibers fray. The mucosal lining of the colon becomes incredibly frail, rigid, and transparently thin. It is no longer thick, forgiving rubber. It transforms into wet, delicate, easily compromised tissue paper. Furthermore, we have to factor in the reality of diverticulosis. Over 70% of individuals over the age of 80 have developed this condition over their lifetime. These are tiny, structurally weak pouches that bulge outward through the muscular wall of the large intestine. During a standard colonoscopy, the gastroenterologist must insert a heavy, flexible tube equipped with a digital camera. To see clearly around the complex, winding anatomical bends of the intestine, they must artificially inflate the colon with carbon dioxide or ambient air, expanding the entire organ like a massive balloon. What do you logically think happens if, in that precise moment of maximal, unnatural stretching, the rigid, paper-thin wall of an 86-year-old intestine, already heavily compromised by dozens of these microscopic diverticular weak points, is subjected to just a fraction of an ounce too much physical pressure from the mechanical tip of the scope or the rapidly expanding gas? It tears. It ruptures catastrophically at its absolute weakest point. By aggressively screening advanced seniors without immense justification, doctors are not just taking a harmless, preventative look around. They are overstressing a fragile mechanical system that is already sitting at its absolute biological limit. Physiologically, inflating an octogenarian's colon is mathematically equivalent to trying to overinflate a vintage, dry-rotted balloon from decades ago. The statistical risk of a physical perforation, a literal, gaping hole ripped into the bowel, spikes exponentially as we age past 75. When this mechanical failure happens, the highly toxic, heavily bacteria-filled contents of the lower digestive tract spill instantaneously directly into the sterile, pristine abdominal cavity. This violent breach causes immediate peritonitis, an agonizing, catastrophic internal infection that quickly cascades into severe systemic sepsis, rapid multi-system organ failure, and in a devastatingly high number of cases for seniors, inescapable death. Believing that a routine mechanical screening is risk-free for your elderly parent is magical thinking that purposefully ignores the hard laws of biomechanics. If you are finding this breakdown of medical realities helpful, please take a quick second to hit the subscribe button so we can keep bringing you unfiltered health truths. Moving away from the physical trauma of the camera itself, we must address a massive systemic danger that occurs long before the patient even arrives at the clinical facility. The immense danger actually originates in your own bathroom, 24 to 48 hours earlier, during the grueling phase known as the bowel preparation. To secure a perfectly clear, unobstructed visual field of the colon walls, the entire lower intestine must be immaculately emptied. To achieve this unnatural state, doctors routinely prescribe highly aggressive osmotic laxatives, compounds like polyethylene glycol, or massive doses of sodium phosphate. We are talking about forcing a fragile, elderly individual to consume several liters of harsh, thick, heavily salted chemical liquids designed to violently flush out the body's entire digestive contents over hours of agonizing, exhausting bathroom trips. For a robust 40-year-old, this is merely an uncomfortable, annoying evening. For an 86-year-old, it is a catastrophic, unmitigated metabolic earthquake. When you chemically force an elderly body to excrete such massive, unnatural amounts of intracellular fluid, you are rapidly draining the cardiovascular system's vital reservoir. Blood volume drops precipitously, plunging the patient into a severe medical state called clinical hypovolemia. Furthermore, you are not merely losing plain water. You are aggressively flushing out critical, life-sustaining electrolytes, primarily sodium, potassium, and magnesium. Consider the electrical wiring system of a complex building. Your heart is the primary generator, and those trace electrolytes act as the precise wiring that keeps the cardiac rhythm perfectly steady and synchronized. Potassium and magnesium dictates to the heart muscle exactly when to fiercely contract and when to properly relax. When you violently purge these essential minerals from an older person whose aging kidneys are already significantly slower to regulate internal balances, you completely disrupt the entire electrical grid of their body. The physiological consequences are immediate and terrifying. The heart begins to flutter, skip beats, or plunge into dangerous, chaotic arrhythmias like atrial fibrillation. Because there is no longer enough fluid volume circulating inside the arterial pipes to maintain structural pressure, the blood pressure plummets dramatically. The kidneys, suddenly deprived of adequate oxygen-rich blood flow, can easily slip into acute renal failure. This intense chemical dehydration can even trigger what medical professionals call third spacing, a phenomenon where vital fluid shifts inappropriately into the wrong anatomical compartments, causing dangerous localized swelling while further dropping systemic blood pressure. We have documented thousands of tragic cases where elderly patients suffer ischemic strokes or massive, fatal heart attacks on their bathroom floors the night before their scheduled procedure, simply because the chemical preparation induced severe, unrecoverable cardiovascular collapse. Do not ever treat aggressive bowel prep like a harmless sports drink. For a fragile senior, it is a massive, entirely unregulated chemical stress test on their heart and kidneys. We must now navigate into the quietest, yet most profoundly damaging error of all, the administration of deep sedation. Often out of pure compassion, family members are scared of the procedure hurting their loved ones. They think, just put them completely to sleep. Give them the heavy medications. It's better if they don't feel a single thing. While this sounds deeply empathetic, in reality, you are legally consenting to a physiological gamble that absolutely terrifies specialized, highly trained geriatric anesthesiologists. You must fundamentally understand how modern anesthesia and heavy intravenous sedation work. Synthetic drugs like propofol, midazolam, and fentanyl are not simple reversible light switches. You do not just turn an elderly brain totally off and then click it perfectly back on 30 minutes later. These powerful chemical agents work by heavily depressing the entire central nervous system, paralyzing normal, protective muscular reflexes, and forcefully suppressing the autonomous respiratory drive. Herein lies the deadly, invisible trap. In an older, aging brain, the neural pathways and synapses are significantly less resilient. The crucial blood-brain barrier, which typically acts as a fortress keeping harsh toxins out of the cerebral tissue, becomes much more permeable and leaky over the decades. When you flood an 86-year-old's brain with heavy, fat-soluble synthetic sedatives, the pharmaceutical molecules linger far longer than intended. They do not neatly process out in 2 hours through the liver and kidneys like they do in a vibrant young body. Instead, they remain stubbornly trapped in the adipose tissues and bloodstream for days, sometimes even extending into weeks. Imagine placing a complex vintage car engine into a deep chemically frozen hibernation and then expecting it to roar back to flawless, perfectly timed life with a simple turn of the ignition key. Human biology does not function that way. A staggering number of seniors wake up from routine sedation, trapped in a condition known medically as post-operative cognitive dysfunction. They become violently, inexplicably delirious in the recovery room. They fail to recognize their own immediate surroundings or their own children standing beside them. Their short-term memory slips terribly. Tragically, in many documented cases, this heavy chemical brain fog never fully lifts, acting as a potent catalyst that permanently accelerates the onset of severe dementia-like symptoms. Furthermore, heavy sedation severely suppresses the natural breathing reflex. An older person's chest wall is already physically rigid, and their total lung capacity is naturally reduced by age. If their breathing becomes too shallow during the prolonged procedure while they lie passively on their side, their circulating blood oxygen levels drop silently and dangerously. This microscopic, unmonitored lack of oxygen delivery to the cerebral cortex during the test can cause thousands of silent, cumulative microstrokes. And from a pure mechanical safety standpoint, my father didn't just suffer a physical puncture, his frail body was heavily, deeply sedated. This meant his natural evolutionary pain reflexes, which would normally scream out, tense up, and physically flinch to warn the doctor that a catastrophic tearing was occurring, were chemically silenced. He was stripped of his biological alarms. If this information is opening your eyes to the hidden realities of senior healthcare, hit the like button so this video can reach and protect more families. Having discussed the profound dangers, we must transition to the modern, life-saving solutions that are too often ignored. What if you could definitively screen for colon cancer without ever stepping foot inside a surgical center, without starving for 2 miserable days, without drinking toxic chemical laxatives, and without risking dangerous brain-altering sedation? Here is where we explore the incredible, non-invasive modern medical miracles that many rushed, heavily protocol-driven clinical doctors either ignore or actively dismiss, simply because it does not fit neatly into their highly lucrative standard operating procedures. I am not suggesting unproven, alternative internet remedies lacking scientific rigor. I am talking about pure, peer-reviewed, hard clinical science, advanced fecal immunochemical tests, sophisticated DNA stool tests like Cologuard, and high-resolution CT colonography. When a cancerous malignant polyp begins to grow inside the colon, it does not just sit there silently. It bleeds on a microscopic level, and more importantly, it continuously sheds abnormal, heavily mutated DNA cells directly into the passing stool long before it ever causes a single physical symptom. Modern molecular biology allows us to simply collect a small, painless stool sample from the absolute comfort, ultimate privacy, and total safety of your own home bathroom and mail it to a highly specialized genetic laboratory. The lab then analyzes that exact sample with incredible molecular precision, actively hunting to detect these hidden, microscopic blood molecules or explicitly mutated cancer DNA. Alternatively, if a physical visual inspection is truly, absolutely medically warranted, there is the virtual colonoscopy. This is a brilliant, entirely external 10-minute scan where an advanced CT machine captures a highly detailed, comprehensive 3D digital image of the entire colon interior. Absolutely no dangerous sedation is required. There is zero recovery time. You walk into the imaging center, the scan is done externally, and you walk right back out to your car. I need you to permanently anchor this core concept into your mind. Non-invasive screening represents the ultimate impenetrable protective shield for the elderly population. Why mathematically risk physically puncturing the fragile colon of an 86-year-old when a simple, brilliant lab test or a quick external scan can tell you with highly comparable accuracy if there is an actual urgent oncological problem? The extensive clinical studies are crystal clear on this matter. For patients of advanced age, the immediate physical risk of performing a colonoscopy drastically, undeniably outweighs the statistical risk of succumbing to slow-growing colon cancer. Biologically, colon cancer is almost universally a very slow-progressing lethargic disease. If an 86-year-old develops a microscopic stage 1 polyp today, it will statistically take between 10 to 15 entire years to mutate and grow enough to become an active, life-threatening mass. mathematically and biologically, that patient is infinitely more likely to pass away peacefully of entirely natural, unrelated causes at 95 than they are to die from a tiny, totally asymptomatic polyp discovered at 86. Yet, the risk of physically tearing their colon wall, permanently ruining their aging kidneys with the harsh chemical prep, or irreversibly damaging their cognitive function with deep anesthesia is fiercely immediate. It happens right there, instantly, on the cold examination table. We are halfway through these vital warnings. Please drop a comment below sharing if you or a parent have ever experienced a surprisingly harsh reaction to a routine procedure. Your story might validate someone else's experience. If your standard medical provider aggressively demands an invasive colonoscopy for a frail, elderly patient without first eagerly offering a DNA stool test or a FIT test as a viable frontline alternative, they are fundamentally failing to practice appropriate modern geriatric medicine. Incorporating these brilliant, non-invasive molecular tests into your preventative routine is infinitely smarter, safer, and more logical than waiting for a catastrophic medical emergency to react. It is painless, highly effective, and completely mathematically eliminates the risk of a lethal mechanical perforation. We now arrive at one of the most dangerous, deeply ingrained psychological barriers that exists when managing the complex health of a senior citizen: the blind, unquestioning, culturally conditioned obedience to the white coat. You have absolutely heard this phrase 1,000 times from older generations who were raised in a completely different, highly paternalistic era of medicine. The doctor always knows best. If the doctor ordered it, we simply have to do it. Who am I to argue with a medical degree? I want you to completely eradicate that subservient, dangerous mindset from your operating system forever. If you are managing your own health or the fragile health of an elderly parent within today's hyper-industrialized, volume-driven healthcare system, blind obedience is your absolute greatest enemy. Let us clinically analyze what actually happens behind the scenes inside the massive medical machine. Imagine a busy gastroenterologist who is forced by hospital management to see up to 40 different patients a day. They operate within a perfectly efficient, highly lucrative conveyor belt system, following rigid, standardized protocols written by distant corporate health boards. Their computer screen flashes an automatic, unthinking algorithm reminding them: patient is 82, mathematically due for colon screening. The rush doctor simply clicks the digital button to order the colonoscopy. It is an automatic, thoughtless reflex. It is also, notably, a highly billable, revenue-generating procedure for the clinic. But what that cold computer algorithm completely fails to see is the nuanced human reality sitting right there on the crinkly paper of the exam table. The software doesn't see that your father has a newly developed, slight heart murmur. It ignores that your mother now struggles simply to walk from the bed to the bathroom without losing her breath. It does not account for the fact that their skin is now as thin, bruised, and fragile as delicate tissue paper. If, at that pivotal moment, you nod quietly, accept the printed appointment slip, and walk out of the door without asking hard, uncomfortable questions, you are falling into a massive, potentially fatal trap. You are sacrificing personalized, compassionate, risk-adjusted care for standardized, mechanical, corporate processing. You must instantly become the aggressive, unapologetic gatekeeper of your parents' physiological health. What does this mean practically, in plain English? It means you must demand a formal, highly specific, risk versus benefit analysis out loud, looking the attending physician directly in the eye. When the doctor casually suggests an invasive, sedated procedure for someone well over 75, you must firmly, politely, but immovably ask, "Doctor, given my father's specific advanced age, his current frailty, and his cardiac history, what is the exact statistical likelihood that finding a polyp today will actually extend his life expectancy, versus the immediate, fully documented risk of a severe complication from the chemical bowel prep, the deep sedation, and the physical scoping itself?" If the physician brushes off your highly valid concerns, becomes visibly defensive, or attempts to professionally intimidate you with jargon, that is a massive, glowing red flag. The absolute secret to survival in modern, industrialized medicine is the concept of shared decision-making. A truly exceptional, compassionate geriatrician will look at an 86-year-old and honestly say, "The standard bureaucratic guidelines say we should screen, but my clinical medical judgment says the immediate, visceral risks of the procedure far outrank the distant, hypothetical risks of the cancer." Let's skip the invasive route, or just do a simple, safe stool test. Do not play Russian roulette with your parents' fragile internal organs just to satisfy a corporate clinic's screening quota. They desperately need your fierce advocacy, your unyielding protection, and your loud, confident voice in that sterile room. Share this video right now with anyone you know who has elderly parents. It is crucial we spread this exact knowledge to prevent unnecessary tragedy. Now, we must deeply examine a terrifying clinical reality that doctors almost never explain during the brief 10-minute consultation. Sometimes, the ultimate tragedy doesn't happen instantly on the bright operating table like it did with my father. Sometimes, it is a silent, creeping, insidious enemy that strikes viciously in the middle of the night, long after you mistakenly believe you are entirely safe. Many families are completely shocked and devastated when their elderly parent goes home after a colonoscopy, seems relatively fine and stable for 12 hours, and then suddenly collapses in the hallway with a raging, uncontrollable fever. They logically think, but the doctor smiled and said everything went perfectly. They gave us the official all clear. What you are completely unaware of is the hidden, delayed reality of the microperforation, or what surgeons call a delayed thermal injury. You must deeply understand the physics of how surgical tools operate inside the human body. If the doctor visually locates a small, seemingly harmless polyp, they do not just politely cut it off with a microscopic knife. They utilize a tiny, electrically heated wire loop to physically burn it off and aggressively cauterize the surrounding tissue to stop bleeding. This technique is called a snare polypectomy. Sometimes the intense, radiating heat from that electrical tool causes a severe delayed thermal injury to the already paper-thin colon wall of an older patient. The catastrophic disaster is not immediate. The structural wall is severely burned, heavily weakened, but technically still physically intact. The patient wakes up, drinks some apple juice, and goes home to rest. But 24 to 48 hours later, that dead, thermally burned tissue eventually sloughs off, and a microscopic hole suddenly opens up directly into the abdomen. Slowly, insidiously, highly toxic, lethal bacteria from the forming stool begin to leak continuously into the pristine, sterile abdominal cavity. This process is slow, treacherous, and highly deceptive. Remember that in the elderly, the natural immune system response is severely blunted and delayed. They may not instantly spike a massive, obvious fever like a young person would. The deadly sepsis actively hides from you. Your father might eat a normal bowl of soup at 7 in the evening and feel just a little unusually tired. But by 3 in the morning, his resting heart rate is racing at a terrifying 130 beats per minute. His breathing is rapid and extremely shallow, and his abdomen is becoming rigidly, painfully distended. This is the absolute point of no return danger zone. Many post-colonoscopy fatalities happen days later because the family logically assumes the escalating pain is just normal trapped gas from the ambient air pumped in during the procedure. Yes, some mild passing bloating is perfectly normal, but severe, localized, escalating pain is a massive, screaming physiological alarm bell. If an elderly person ever complains of a sudden, sharp, deeply localized pain that does not resolve with passing gas, if their stomach physically feels hard to the touch like a wooden board, or if they develop sudden, uncontrollable shaking rigors and chills, their body is desperately screaming that there is a toxic, lethal internal leak. For a senior citizen, ignoring these subtle, creeping signs for even 4 short hours can be definitively, irreversibly fatal. The bacterial infection violently spreads from the localized abdomen directly into the systemic bloodstream incredibly fast, causing irreversible septic shock. Extreme paranoid vigilance is your best, only strategy. You must watch them like a hawk for a full, uninterrupted 72 hours following any invasive gastrointestinal procedure. Finally, we arrive at the absolute red line. We have talked extensively about risks, chemical preps, and modern alternatives, but there is a definitive, uncompromising boundary. There is a red line that, if ever crossed, you cannot allow yourself to wait another minute, and you must take absolute, authoritative control of the medical situation. I want you to burn this specific demographic age bracket into your permanent memory, forever, 75 to 80 years old. According to major, highly respected, data-driven medical organizations like the U.S. Preventive Services Task Force, routine preventative colon cancer screening should firmly, officially stop at age 75. Between the ages of 76 and 85, it should only be performed in highly selective, extraordinarily rare cases, and for absolutely anyone over the age of 85. It is almost universally, officially recommended against by true experts. If a doctor attempts to aggressively push a routine screening colonoscopy on an 86-year-old who currently has absolutely no active, terrifying physical symptoms, that doctor has crossed the red line of medical overreach, and you must step in. But be extraordinarily careful. Here is the vital, clinical key that distinguishes dangerous medical abuse from necessary, life-saving intervention. The massive difference between unnecessary prevention and vital harm reduction is the distinct presence of active, dangerous, undeniable symptoms. If your elderly parent is feeling perfectly fine, eating wonderfully, maintaining their normal body weight, and has totally pristine, normal blood work, and the physician just wants to take a quick look just to be perfectly safe, you must firmly, unequivocally, legally decline. In that scenario, the risk is the procedure itself. However, if your parent is actively experiencing any of these four specific, terrifying things, you are facing a true, undeniable medical necessity where the immense risk of the invasive procedure must be heavily weighed against a clear and present active danger. 1. Unexplained, severe clinical anemia, representing a sudden, drastic, terrifying drop in red blood cells, indicating that they are actively, heavily bleeding internally somewhere you cannot physically see. 2. Visible, significant, undeniable blood in the stool. We are not talking about a tiny microscopic speck on the toilet paper, but dark, tarry, foul-smelling stools, or large amounts of fresh, bright red blood pooling in the bowl. 3. Severe, entirely unexplained, rapid weight loss combined with chronic, grinding, unrelenting abdominal pain. 4. A sudden, complete, and total paralyzing change in bowel habits, such as an absolute inability to pass stool or gas for multiple days, strongly indicating a physical, life-threatening tumor blockage. In these extreme, highly specific, critical scenarios, a physical diagnostic test might be absolutely, undeniably required to save their immediate life. But even then, in that extreme emergency, you must actively be the fierce negotiator. You must explicitly demand the most gentle, low-volume chemical prep currently available on the market. You must demand the lightest possible, perfectly monitored sedation, handled exclusively by a dedicated, board-certified anesthesiologist, not a distracted nurse anesthetist aggressively multitasking. And you must demand the absolute most experienced senior attending doctor on staff to physically perform the delicate procedure, refusing to let a resident or fellow practice on their fragile tissues. And if, heaven forbid, you are at home after a procedure, even a seemingly flawless, highly successful one, and the patient rapidly develops that terrifying, board-like rigid abdomen, a sudden spiking high fever, or extreme, unrousable, terrifying lethargy, forget calling the clinic to leave a polite voicemail with the receptionist. Forget offering them a mild painkiller and blindly hoping they just sleep it off until the bright morning. Do not attempt to put them in the passenger seat of your personal car to hastily drive them yourself. They could easily slip into irreversible hypotensive septic shock on the highway, and you will be entirely helpless, trapped in traffic. The only thing you must do in that exact terrifying second is unlock your phone and call emergency services immediately. State clearly, loudly, and without hesitation to the medical dispatcher: "My elderly father recently underwent a colonoscopy, and he is currently showing acute textbook signs of a bowel perforation, severe peritonitis, and advancing septic shock. We need paramedics dispatched immediately." In the realm of severe internal infections, time is literally tissue. Time is human life. Every single minute you hesitate at home, nervously pacing the floor and trying to amateurishly assess the complex medical situation yourself, irreversible, catastrophic cellular damage is being actively done to their vital organs by the overwhelming, cascading bacterial infection. It is infinitely, undeniably better to call the ambulance, rush violently to the emergency room, and have it be a total, slightly embarrassing false alarm, than to not call, attempt to bravely ride it out, and have it be permanently, tragically, and unchangeably too late. You now possess the precise tools, the specific medical vocabulary, and the authoritative knowledge to turn passive, dangerous acceptance into fierce, life-saving advocacy, ensuring that your loved ones live their remaining years with dignity, absolute safety, and unbroken independence. Thank you for watching. Please let me know in the comments what other senior health topics or medical procedures you want me to investigate and break down for you next.